All right, let's talk about your respiratory assessment, kind of a special respiratory assessment. So we're going to kind of break respiratory distress out into a few stages. So that first stage, not too bad. That last stage, horribly bad. You're dead, right? So stage one, a little tachypnea. You're breathing a little bit too fast, but everything else is going all right. So as we kind of progress through, we start to get some pursed lips. We're kind of creating our own PEEP, trying to keep our own alveoli open and recruited physiologically. So as we move into stage two, you might see some pursed lips. Stage three, stage four, we've got intercostal retractions. We've got accessory muscles going on. Um, we're tripoding. We're using our pursed lips. We're definitely tachypnic. So we're kind of adding on signs, adding on symptoms as we progress through our stages of respiratory distress. Once we get into stage 5 and 6, this is the bad times, right? So stage 5, we're talking about organ failure. We've got cyanosis going on. We've got cyanosis in the capillary beds. We've got cyanosis in your mucosa. We're just seeing cyanosis from the outside. That means that we aren't getting oxygen to where it needs to be. We've got organ failure starting. Once we get to stage 6, we're just going to call that respiratory arrest, and we definitely need to step in at that point. Hopefully, you're doing something by that point. But just now we've got stage 1 through stage 6. Stage 1, not so bad, just a little bit of increased work of breathing, and then we progress through stage 2, stage 3, stage 4. Once we get into 5 and 6, we're going into organ failure, organ death, and we're progressing into respiratory arrest. We can also think of these stages as either compensating or not compensating, when we'll just call that respiratory failure. So stages 1 through 4, we've got increased work of breathing, so we've got tachypnea, maybe we've got some accessory muscle use, but we are compensating. We've got increased work of breathing. We can still do something there to help this patient along and reverse this respiratory distress and get them back into a good spot. Once we move into failure, your increased work of breathing turns into a decreased work of breathing. That'll in turn lead to decreased levels of consciousness. So this is our stages 5 and 6. These are our cyanosis, our organ failures, into our respiratory arrest. So we want to catch our respiratory distress patients in the compensation um, arena in the stages 1 through 4. So we can do something. Um, we can provide an intervention and hopefully reverse that respiratory distress. Talking hypoxia, so just not getting enough oxygen to your cells. We'll break those out into categories as well. So we've got mild, moderate, and severe. Our mild hypoxia starts around 94% for just normal people. Once we get below 94%, and this is taking an SpO2, once you get below 94%, your patient's going to start feeling it, right? So, and this is going to be patient dependent. If you've got that patient with a long history of COPD, 94 might be their normal, and they might be functioning just fine right there at 94, 93, 92. But for this is just talking normal people, you and I, if we go below 94% or so, we're going to start feeling it. And then once we go below 91%, we're going into moderate hypoxia, and these are just kind of official definitions for you. Moderate hypoxia, and then once we hit kind of mid to upper 80s there, below 86% or so, we're going into severe hypoxia. All right, now is a good time to talk about PEEP and really talk about why PEEP is so important. So we have normal PEEP every day. This PEEP keeps our alveoli open, recruited, keeps our lungs from collapsing into each other, kind of sticking to each other on the inside. So our positive end expiratory pressure, we can think of this as alveolar pressure, so pressure exerted on our alveoli, and it's the pressure inside our airway at the end of exhalation. So how much pressure is present on the inside of kind of our system and inside of our airways at the end of exhalation. This keeps our alveoli open again. So normal PEEP, 2 or 3 centimeters of water is kind of our normal PEEP. You might see pressures with units of centimeters of water. You might see it as millimeters of mercury. Those are the same thing, just when we're talking respiratory-wise. Not quite sure off the top of my head, but respiratory therapists and The respiratory community likes to use centimeters of water instead of millimeters of mercury, so we'll probably be talking about these things in centimeters of water, even though you might see them in millimeters of mercury somewhere else. So normal PEEP, 2 or 3, just every day walking around. So if we look at this visual right here, on this left-hand side, we've got this FRC. Remember, that's our functional residual capacity. That's the air left in our lungs at the end of both a normal breath. Let's pull this up here. So at functional residual capacity, and of our residual volume and our expiratory reserve volume. So the air in our lungs at the end of a normal respiration. So our functional reserve capacity, the air in our lungs at the end of a normal respiration. So I've got some issues going on here, right? And I don't have any pressure in my lungs, right? So if I add some PEEP, I can keep my lung open. I can keep my alveoli here. You can see these. I can keep these open. So if I add some PEEP, I keep my alveoli open. I keep them recruited. So adding PEEP is just adding pressure into that airway system after expiration. As we continue to assess our respiratory distress patient, we need to kind of figure out what's going on with the respiratory state, and that a large part of that goes into the VQ ratio. So there's going to be an issue. Our respiratory distress patient is going to have an issue with their VQ ratio, and we need to determine whether it's a V or it's a Q issue. So our V in this ratio is ventilation, so that's air going in and out. Is there an issue with air going out or air coming in? Or Q, which is obviously stands for perfusion. Is there an issue with perfusion and blood going round and round in our pulmonary system and blood getting to the alveoli? So I can have an issue with air going in and out with our alveoli, or I can have an issue with blood going round and round our alveoli. First one we'll talk about right to left shunt is where we are ventilated but we're not perfused. So I've got air coming in and out just fine, but for some reason I don't have blood going round and round to all of my alveoli. So if I don't have blood going round and round, I've got that oxygen coming in. That's great, but I can't swap it with my carbon dioxide on my hemoglobins. So that air coming in and out is just doing that. It's just coming in and out. It's not being swapped with my carbon dioxide on my hemoglobins. The other one, the pulmonary shunt, that's just the opposite. I am perfused, but I'm not ventilating properly, so my blood is going round and round. The hemoglobins are there, ready to swap carbon dioxide for oxygen, but I don't have oxygen coming in. I don't have that air coming in and out. So that's our pulmonary shunt. And then just kind of an aside, it's just an issue of high altitude. As we go higher and higher in altitude, just the normal FiO2 is going to go down and down. So if you're into mountaineering, if you watched any mountaineering documentaries, see once they get into high altitude, they might have some supplemental oxygen. It's because when you go higher and higher in altitude, our normal FiO2 here at ground level, which is about 21%, it's going to drop 20, 19, 18, 17, 15%, and that's going to present its own kind of VQ ratio issue. But I just want to point that out to you. We're going to focus on right to left shunts, and we're going to focus on pulmonary shunts. So is it a ventilation issue, or is it a perfusion issue? We can actually calculate our VQ ratio. So you were just kind of taking a normal person, and a normal person moves about 4 liters per minute of air in and out of their lungs. And a normal person has about 5 liters of blood kind of perfusing through the body every minute as well. So our VQ, so our V over our Q, our air over our perfusion, 4 over 5 is 0.8. So we can call a normal VQ ratio 0.8. For convenience sake right now, we'll just say a normal VQ ratio is 1. So anything less than 1 or greater than 1 is going to be a little off and be a little weird. If my VQ ratio is greater than 1, again, something's weird if it's greater than 1 or less than 1. So here in this case, it's greater than 1. We've got a right to left shunt. what we would call a right to left shunt. So our lungs are ventilated. We've got fine air coming in and out, but our lungs are not being perfused, or not every single part of our lung is being perfused. So we call a left to right, a right to left shunt, because we can think of this as kind of bypassing the lungs. So what if our blood were to go directly from the right ventricle to the left ventricle? If we did that, we've got unoxygenated blood from the right ventricle going straight into the left ventricle and then being circulated throughout the body. We have that essentially here. We've got blood going from the right ventricle into the lungs, but it's not picking up any oxygen because there isn't 100% perfusion. There's a perfusion issue, so it comes back to the left ventricle and hasn't picked up anything, and then is circulated out to the body. So this right to left shunt, VQ ratio is greater than 1. Our lungs are ventilated, but they're not perfused. Most common cause for a right to left shunt, again, our VQ ratio is greater than 1, is pulmonary embolism. So I've got a clot in my pulmonary system, so I'm not going to get complete perfusion to all of my alveoli, even though those alveoli are getting air in and out just fine. They're not getting the perfusion around them to swap our gases, our oxygens, and carbon dioxides. There's also tetralogy of Fallot, which is in children, newborns, infants. We'll let Dr. Wilson talk to you more about that in her PEDS course, but the most common cause of a right to left shunt, a VQ ratio greater than 1, would be a pulmonary embolism. On the other side of things, we've got a VQ ratio of less than 1. We'll call that a pulmonary shunt instead of a right to left shunt. So our VQ ratio is less than 1. Our lungs are perfused, so blood is going round and round our alveoli just fine. No problems with that, but they're not ventilated. We have an issue with air coming in and out. So if we have an issue with air coming in and out, what would cause that? Well, a pneumothorax, be it simple or tension. We've got an issue with air coming in and out. So circulation is just fine around our alveoli, but we've got an issue with air coming in or going out. Also pulmonary edema, very common cause of this pulmonary shunt. This VQ ratio less than 1 here. So pulmonary edema, and also think COPD, asthma, and other acute conditions that would cause issues with air coming in and out, because blood is going round and round just fine, but we're just not getting the oxygen in there to swap with our carbon dioxides. So how do we know? How do we assess the VQ status? Well, we can calculate our own VQ status. We can just know based on the presentation of the patient and our assessment whether or not it's a ventilation issue or a perfusion issue. At the hospital, we can do a VQ scan, and this is part of nuclear medicine. So we are kind of putting in radioactive materials into our patient and kind of seeing what happens. It comes in 2 stages. So first, the patient will breathe in, kind of nebulize in this radioactive material, and then is scanned. So there on the left we see this the ventilation portion of this VQ scan, and this shows us if there's a ventilation issue. So is this radioactive material going in and out just fine? If it is, it'll show up on the scan. Second one is radioactive material is injected into the bloodstream via IV and then scanned again. Here on the right hand side we've got perfusion, so we're looking at perfusion of the lungs, and is there an issue with perfusion? This is all through a gamma camera picking up that radioactive material. So on this patient here, we look at ventilation, and that looks just fine. We can see both lungs. We can see the outlines of both lungs pretty clearly. On the perfusion side, this right lung looks pretty good. We can pick out the structure of that lung. On the left-hand side, though, their left lung looks a little off right there, right? So we see a big gap right there. So on this VQ scan, we can see that there's a perfusion issue, so we might be dealing with something like a pulmonary embolism. If you have any questions, comments, concerns, or cuss words, please feel free to let me know.